Welcome. I think we'll probably get started here in a sec. How many are patients and families here? Are there, oh yeah, okay. Patient families? Yeah, okay. Any physicians or pharma? Okay. Oh, industry. Okay, excellent. Okay. Welcome. I'm Jason Springer. I am a rheumatologist at Vanderbilt. And if you are here to talk about IgG4 related disease in the lungs, you're in the right spot. So, this is going to be a very interactive session. I will give you a little bit of a physician's perspective initially. We'll talk about some of the basics of like lung anatomy. We'll go over various ways that IgG4 can affect the lungs and what it looks like. But most of this is really going to be in an interactive session, and we'd like to really get your experiences with this. I've got some discussion questions and can also ask general questions as well. So let's just start with the lungs in general. The lungs, you have the main airway, which is a trachea. So this is what goes in your windpipe that comes down, and eventually this is going to spread into the bronchi that go into the lungs. And these branch out into smaller and smaller branches, and we call these each branch is primary, secondary, and tertiary bronchi. And eventually, when these get small enough, they're going to be called the bronchioles. This airway system will then end in what's called the alveoli. And so that's what's shown there, those little grape-looking things. So that's the end of the airways, and that's where all the action happens. So that's where gas exchange occurs. So you can see that around these little sacs, there are some blood vessels. And so oxygen will travel through there into the blood, and some of the waste products like carbon dioxide will travel out into the airways, and then we expel them. The lungs, they're in a sac called the pleura that surrounds both of the lungs, which isn't shown here on this picture. And then in the middle, between the lungs, this is what's called the mediastinum. So within the mediastinum, there's a lot of structures, including lymph nodes. And we call this area where the airways go in the hilum of the lungs. So in terms of ways that IgG4 can affect the lungs, so it can affect the parenchyma, and that's the gas exchange component of the lungs. You saw the alveoli there in the surrounding areas. It can also affect the blood vessels in the lungs as well as the airways. Sometimes it can cause thickening of that lining around the lungs. And also it can cause enlarged lymph nodes. Typically that's going to be in the mediastinum, that area in between both of the lungs. Or it can be in that hilar area that we showed earlier. It can involve the major airways, the trachea and the bronchiole, sometimes causing narrowing of these airways and difficulty moving air through these areas. And it can also cause scar tissue in the areas between the lungs, what we call sclerosing mediastinitis. So most commonly, it's going to be within the lungs themselves. And there's four basic ways that it can affect the lungs, which are shown here. So it can cause these solid nodular appearances. So that's shown in A. And so if you imagine the kind of white area is the parenchyma of the lungs, and then you see some airways and blood vessels. And so you see this solid mass there right in the lungs. And this can sometimes be confused as cancers, like a lung cancer. Also, it can cause these round-shaped ground glass opacities. That's shown in B there. So you can see if you imagine glass being ground into a fine sediment, and so it kind of looks like that, and that's why it's described as ground glass opacities. So you might see that on like CT scan reports and stuff, and that's what they're referring to. And they tend to have this roundish appearance. Also, you can get alveolar interstitial involvement, and that's what's shown in C here. A lot of times it'll be more peripherally in the lungs. You can see it kind of has this honeycombing pattern, and that tends to be scar tissue. It tends to be more damage. And you can also have bronchiovascular involvement, so you can get thickening of the lining around the airways and the blood vessels. So what does this look like? These are CT scans of the chest. Now, just to orient you, so when they show you CT scans, it's like the head is down that way, out, into the screen, and the legs are out this way. The chest is up above, and the back is down. And so, when on the right, that's their left, and on the left, that's their right. So you can see the black arrow. So there's one of those solid nodular appearances. The white arrow is one of those ground glass areas that we were talking about. On the left here, so this is the alveolar interstitial changes where you see kind of that honeycombing pattern. And one of you mentioned white out in the lung. So maybe they were talking about something like this, where on the top here, it's very opacified. And then on the right here, you can see thickening of these airways. So these are all airways, the bronchi, and they're not very smooth. They're very lumpy there. And you can see that a lot of them are very tight. These are showing, again, some roundish ground glass opacity areas. And then on the bottom here, you can see that alveolar interstitial changes. Again, that is scar tissue, in kind of this honeycombing pattern there at the bottom. And you can even see some thickening right around some of the airways there, which is shown with the white arrows. In these pictures, we're seeing thickening of the airways. Again, you don't see that smooth appearance of the airways. It kind of has that lumpy pattern, and some of these are very narrowed as well. This has several things. So there are some solid nodular areas shown in the white areas, and also an area of ground glass opacity. So those are what it looks macroscopically. So what does this look like microscopically if you were to look at this? So this shows that solid nodular type. And so this has been resected. And you can see even there is probably some thickening around one of the airways here. And if you look at the slides here, you see something that you saw in one of the slides earlier. So those little purple dots, is anybody a pop quiz? What are those? What? All right. Yes. You guys get an A. Good job. So yeah, those are lymphocytes. So those are inflammatory cells that are attacking the tissue. Within this area, you can also, if you look in this picture, there is some airways that are small airways, bronchioles that are involved there as well. This is the bronchovascular type. So these are right around some of the airways. And so you can see an airway in D here. You can see some thickening and some pinkish material, which shouldn't be there. There's a lot of purple dots there, so a lot of inflammation going on there. Also, in some of these pictures, probably it's best here in G. Again, you see a lot of these lymphocytes or purple dots, but you also see some that have this little kind of pinkish material in them. Well, what are those? There you go. Yeah. Yeah, good. Eosinophils. Yeah, so you can get eosinophils in these as well. And then on the eye here is showing staining for IgG4. So you do have to do special staining for IgG4. So it's not something they commonly do on all biopsies. You actually have to tell them that I'm looking for IgG4 disease so that they can do that special staining and see all these cells that are showing up as brown are IgG4 positive cells. And this is the alveolar interstitial type. And this is where it's forming scar tissue kind of in the scaffolding of the lungs. And again, you can see all those inflammatory cells. And then if you ask them to stain for IgG4, you see those brown stained cells. But it can also cause destruction of the blood vessels. So what we're seeing here is destruction of veins and arteries within the lungs. So on the left here, this is actually a vein. You should see a lumen here. You should see an opening where blood flow should go through, but you don't see that. There's been destruction here. Also, this black line around the periphery, that's part of the wall of the blood vessel. And so this should go all the way around the blood vessel, and you can see there's discontinuity of that of the blood vessel wall there. On the right here, this is an artery. You can see it's a little more thicker of the blood vessel wall there. On the right here, this is an artery. You can see it's a little more thicker. And again, you don't see a lumen, no opening. There should be an opening in the middle. And you see two lines, and this is the arterial wall, the internal and external elastic lamina. And again, those should go all the way around, and you can see there's discontinuity there. And so there's destruction of the vessel wall. And then this is just showing the positive IgG4 staining, and specifically they're staining what's called plasma cells. So that's my part of it. Now this is meant to be a very interactive session, so I think it would be very helpful to have a patient perspective. And if you guys want to share your story, that's great. I'd like to hear how your lung involvement manifested. And was it difficult to recognize IgG4 in the lungs by your medical team? So anybody want to start?
Really kind of backtracking just a little bit, that when you talk about the images and show the images, is it always required to have contrast to get those images? Or is an image taken without contrast dye going to not show an issue that may be IgG4 related?
So in relation to IgG4, you actually don't need contrast because most of it's going to be right in the parenchyma of the lungs. And so you don't need contrast for that. If you're going to image the blood vessels, primarily the large blood vessels, then you need contrast, but actually a non-contrast does very well.
The reason I came in here and joined the session isn't because I've been diagnosed with a lung problem. I have IgG4 related disease, and I've had a lot of different impacts from that. But I have constantly dealt with severe, sharp stabbing pains all around, like a pleurisy pain, but they keep saying I don't have pleurisy, and it's like maybe my pleuris, and it's often associated with something as just as simple as laughing, or if I cough or if I reach for something, and it just is so severe, and it could be high left, low right, sides, front and back at the same time. Very strange things, and I've never been able to put a finger on it.
Sometimes you can see inflammation of the pleura. So remember, that's the lining around the heart, and you can see thickening there. Sometimes it may be hard to see, on imaging. So it may not come across very well. I don't know if contrast will bring that out. So sometimes that could be hard to see if there's inflammation going on there. Sometimes if there is inflammation, you'll see some fluid around the lungs, and that can be a tip off that there's inflammation in the pleura.
So
Oh, okay.
maybe nobody knows how to see anything. I don't know because they never heard of IgG4 related disease.
Oh, yeah. Yeah. And sometimes these are hard areas to biopsy too, to prove it. You can get biopsies of the pleura, but it's a little bit invasive. So, yeah.
Yeah, hello. I'm a patient with IgG4. For me, it mainly like just affects like the glands in my eyes and then my salivary glands. But when I have like pretty bad flare-ups, I notice that like my breathing is always short. Like I can tell like just having a hard time breathing and stuff. But on top of IgG4, I also have heart disease. So I'm kind of like trying to figure out if the shortness of breath is like or more so, what is the connection of the heart and the lungs? Because when I always get x-rays of the lungs, it always looks normal or like just regular inflammation from like a common cold or flu. So what is like the connection of the heart and lungs? If that makes sense.
Yeah, so there's definitely heart involvement that can occur with IgG4. Now, the CT would be better at picking up. It's a lot more sensitive compared to a chest X-ray. And let's see, as far as our imaging has some limitations, but the other test we have is the breathing test, the pulmonary function test. So that can actually test how well the lung is functioning. It gives us different information compared to the imaging. It gives us information on the function of the lungs, the numbers of how well you're exhaling and inhaling and such. And so that can sometimes help out in terms of differentiating what's the primary driver of the symptoms. Now you also mentioned, a lot of kind of upper airway stuff. Now, definitely some of that can impinge on the airways a little bit and also lead to shortness of breath. Yeah.
So I'm also an IgG4 related disease patient. And I think one of the complexities is always trying to sort out what's what. And I started this journey probably 25 years ago. And before I was diagnosed with this disease, at one point, I'm going to say a decade ago, I started having breathing issues, and the doctor said, it looks like you have eosinophilic asthma. Got that treated, regular medications, responded really well. But when I was finally diagnosed with IgG4-RD and I had my first rituximab treatment, responded beautifully to that. But also at the same time, I had a lot going on. I forgot my asthma medications for the first time in ages. I had no problems. And it made them all say, wait a minute, is the asthma related to that? You are absolutely symptom free once you're in remission with rituximab. But as that time goes on, it's the asthma is slowly creeping back. Do those seem related, or do you see that?
Yeah. So one thing that's interesting to me is did you have other features of IgG4? Was the lung the primarily thing? Oh, you did.
No, no,
Okay.
lots of head and neck issues, salivary glands, eyes, lymph nodes,
Oh, okay.
sinuses.
Because yeah, a lot of in the literature, a lot of cases that have been identified was because of things outside of the lung. So you wonder if the lung involvement is more common than we actually recognize because the lungs are hard to, biopsy sometimes. But anyway, going to your question, asthma is where you get, bronchoconstriction of the, bronchioles. And so definitely if there's inflammation there, it can lead to narrowing of those and maybe a little bit more reactivity. So it may make sense that it would present similar to asthma,
Yeah, that's the question. I'm happy. Things are in good shape with that now, but
Yeah.
it's always hard to know. Again, because the doctors don't, it's hard to get everyone to talk to each other. Understatement.
How did they diagnose eosinophilic asthma?
Oh, so this is kind of a tangent too. My wife happens to have rare respiratory disease, so she goes out to National Jewish in Denver, where it's such a specialty. And my doctor, who was dealing with my IgG4, said, "Why don't you go out there?" And they're the ones who diagnosed that. But that was before IgG4 related disease was named. So this is all, it's all part of the linearity or non-linearity of it all.
Yeah, thank you.
Question just to build on that. You mentioned the prevalence of the lung manifestation and maybe not being as widely recognized. Do you have any idea? And I guess, IgG4-RD doesn't ever start in one organ and then move to the next. Like there's not a pattern there. So any thoughts from you on, does it typically show up like more acutely in the lung so it gets recognized a little bit quicker? And then how many patients actually have lung manifestation that they might not actually know about yet, right? And it's a very tough question to answer. I'm just curious on your thoughts.
My thoughts are I don't know. And so, yeah, I think it can get missed definitely because, these are sometimes they're subtle things, and sometimes smaller nodules may not, incidentally on CT, we do see nodules sometimes that are not significant. We see very small nodules because we inhale things in our environment that sometimes cause little nodules. And so we don't worry about them sometimes until they get big enough. And so, yeah, I think it's probably under-recognized. And I don't have a great sense. I don't think in general we have a good sense of like what the prevalence of the IgG4 related lung disease is. So definitely an area that we need more research in. Yeah.
Yeah, I'm a patient and I was having problems back in October of 2020 with breathing. And I thought maybe I was getting some kind of allergies or something. Up until that point, I was perfectly healthy. And then a lot of fatigue. I went to the doctor and they gave me a Z-Pak. They thought maybe it was pneumonia. And then I didn't feel better. I just kept getting worse and worse. So fast forward about 5 months later, I went into the ER and they told me right then and there I had lung cancer. So it was in the middle of COVID. I was by myself. My husband wasn't able to be with me. So I was shocked because I'm not a smoker. And I did grow up in a smoking house, but I wasn't a smoker myself. So I was seeing a round of, I had a lot of other things going on. I had eye inflammation. I had the salivary glands. I had, lumps in my, neck, and just a lot of things were just going wild with my body. I didn't understand what was going on. So I was seeing, an ear, nose, and throat doctor, an ophthalmologist, a ear infectious diseases doctor, an oncologist, and a pulmonologist. And finally, and I'm in the Boston area, so it was my pulmonologist that hung in there with me, time and time again, and said after I had like a needle biopsy, I had a bronchoscopy, I had a wedge biopsy all in my lung. Finally, he said, I think it might be something that's called IgG4. And he wrote it down on a notepad. And I still have that piece of paper. And I said, what do I do? And he said, well, there's this, lucky for you, there's a well-known doctor in the area at Mass General. And let me see if I can connect you to him. And that's what happened. I got connected over to Dr. Stone. But if it wasn't for my pulmonologist, I don't know where I would be right now.
Yeah, my sense is probably the ones that are presenting with those nodular lesions probably get picked up more because it leads to a biopsy because they're worried about cancer. So let's see who else. Yep.
Yeah, I'm also a patient and I was diagnosed in 2012. Didn't do anything about it until probably 2017 when I did my first prednisone treatment, then waited probably 2 years, did another one, waited until I went to rituximab. I had a lot of lung manifestations, and I had the test done, the stress test, and they said I have asthma. I would respond to inhalers, but it wasn't really helping in the long term. And then I had rituximab infusion, gone, like gone. Up until probably 2 years when I started feeling like, oh, my lymph nodes are coming back. And the first time I had a cold and I had severe bronchitis, went to the emergency. They hospitalized me with pneumonia. And all they keep saying is these round glass-like opacifications. And every time I get diagnosed, it's always with pneumonia, which I don't think it's pneumonia, but I don't know what to tell them. I don't think a lot of people know about the disease. And I just also don't know what to do because my rheumatologist knows the disease well, but the pulmonologist thinks I have asthma, and I don't think I do. And it helps, like the rituximab helps.
Yeah, I think that's a asthma. I don't know of asthma responding to rituximab, so that's probably a good indication that it has something to do with it. I'm interested if anybody, we use inhaled steroids and things like asthma, and I'm wondering if anybody has experience with inhaled steroids and how well that's worked for their lung. Anybody want to comment on that?
I've been suffering with asthma since I was a younger adult in my 30s. It started out of the blue, and I went to rescue inhalers and then went to preventative inhalers, steroidal inhalers, and I've been kind of switching back and forth to that. But I've it's been a very difficult time for me too, because I keep hearing everybody, for me, it started with my glands really bad, huge, terrible. My eyes are bothering me right now. And it moved on. I actually was diagnosed with pancreatic cancer and continued on, but the asthma has just been terrible. It's been a real problem. And that's where I just had an MRI, and without contrast, I'm trying to figure out, is there any way that that's related to this? Because I've had so many areas of impact with the IgG4 related disease. Now, I'm not on rituximab, and I've been fighting with my insurance to get on it. And I keep hearing these great stories from you guys and other people so far today that this sounds like, something I really am longing for. So
I will say I've definitely had frustrations with getting rituximab. And anytime you have a disease where we know it works, but we just don't have FDA approval for it, it makes it challenging. And so I've had several instances where I've had to try something else, which some of the other older immunosuppressive medicines work okay, but yeah, rituximab has I've had a lot of good success with rituximab. But yeah, it's a challenge. Luckily, I think for it being a relatively newer disease, there's a lot of studies going on and a lot of excitement right now. And I think, like things like this, it raises awareness. And so, you'll probably get better awareness with people that are giving these drugs over time. Yes.
Thanks. So I'm a patient with IgG4 related disease, and I was diagnosed because had shortness of breath. And they sent me for CTs and MRIs with contrast. And the radiologist said, I see a nodule here that I'm not happy with, have a PET scan. And luckily I had like the A team of doctors. My primary care was like on it. Yes, let's do it. Came back metabolically active. She got me hooked up with a pulmonologist who fit me in right away, who looked at it and said, I think you have carcinoid tumor syndrome. We need to get this out and looked at. And my friend had just died from that, another rare disease. So I was like, and they bumped me to the top of the surgery list. I got in. So from the time that I went to my primary care to my surgery, it was less than 4 months. That process, very quick compared to so many of you. They did a wedge resection, took out 20% of my lower left lobe, took out the nodule. They told me when I woke up, I had complications. So it was a few days later that I woke up. But they said, it's not cancer. Yay. But we don't know what it is. And then 2 weeks later, the surgeon called me at 11 o'clock at night and said, I just got your results and it's something really rare. It's IgG4 related disease. What's that? He's like, yeah, I have to look it up. So, but I mean, they took out that nodule and they put me on prednisone for 6 months, tapered it down. And that was in 2022. And I've been off prednisone, not on anything else, no new symptoms. So my questions are, how do you monitor for recurrence? My pulmonologist is fabulous, but he's like, I don't want to x-ray you every year. We can't do a PET scan every year. If you have symptoms, come back. I'm like, well, sometimes I get short of breath when I'm walking the dog, but like, is it just because it's a big hill or, and then what's the likelihood of the lung nodule kind of IgG4 manifesting or spreading to other organs, or is it usually just kind of stays in the lungs? It happens in the lungs, it stays in the lungs. Could the surgery be one and done? I had that nodule out and I'm never going to have any other manifestations. My serum is a little high, but not much, like 119, 120 IgG4. So, does it come back? Does it spread? How do you monitor for recurrence? Those are my questions.
So I'll start with the last question, which is maybe the easier of, yeah, it's possible that it may not come back, and monitoring it, I think we're still figuring out the best course. I think it is it's hard to do a PET. PET is great for like diagnostic purposes, but it's hard to use that to follow the disease. Whereas like a CT scan may be reasonable of the lungs, like maybe if things have been stable, maybe every year, and doing like lung function tests, making sure the lung function looks good. Those tests kind of complement each other, the lung function tests and the CTs. So, and yes, sometimes it has this monophasic course where it may not come back, So yeah, so I don't have a perfect answer for you. And IgG4 levels are helpful, definitely. But, if there's a rise in it, then that you'd want to pay attention to that. So I think it is something that should be monitored over time. I don't know that you'd especially start treatment if there's nothing that's concerning, but monitoring is reasonable with some of those tests. In general, IgG4 tends to like to stay in, one area, but, monitoring for those other organs is reasonable as well. Yeah. Yeah.
I don't want to fly in the face of conflict because the experience with my husband, I am not the patient, I'm the caregiver, has been just the opposite. We have been chasing inflammation for years. And so it has manifested as asthma. He's never had asthma in his life. It manifested with swollen lymph nodes. He became severely jaundiced, had a large pancreatic mass. He had to have stented. It's just been a number of things. But with regards to the lungs, he went just on the inhaler treatments. And over time, that has cleared. And it would seem that once we recognized that there was a connection between steroids and feeling better, when we went through the pancreatic cancer scare, which was not, it was a blocked common bile duct from pancreatitis. But for us, it's trying to get, we're chasing inflammation, which causes you to go to various doctors for this, that, and the other. So it's ear, nose, and throat, and then it's hematology, and then it's rheumatoid, and then it's gastrointestinal. It's a very confounding picture for us, and we live in a rural area, and we just don't have the resources available. Like, I'm not sure where I'm going with this other than to say we know there's a connection, but we don't know how to get the proper help. And it was only in desperation of me having another sleepless night that I fell upon Fireside Chats in YouTube and sent a message, and somebody was monitoring the website, and that's what brought us here. So I feel like just being here is a blessing to us because, my God, there's a community of people who've been dealing with the same things that we have, and we've had no answers. We've like, well, you've had COVID, that's why you lost your sense of smell. And, well, you have asthma. Why do I have asthma at 57 years old? I've never had asthma. Prostatitis was another one. And it wasn't until he got so sick with the pancreatitis and needed his common bile duct stented that a group of internists who were Asian, ironically, said, we need to check for IgG4-RD. And that's when we got a definitive diagnosis. But for us, we are just swimming in thirsting for knowledge and information. Like we're tag teaming. He's in the pancreobilitary whatever session, and I'm over here with lungs. So we can just get as much information. So I know how to help and support him. And ironically, he's been off of the inhalers now for about 3 months. He had an asthma attack last night here in the hospital. So we just never know what we're dealing with. And we don't always have what we need at the time.
Who's your care? Who's like the quarterback of the team, so to speak, or is there one? Yeah.
About it. And we live in the third most populous state. We're in Florida. And we have, my husband's a PhD grad from University of Miami, and University of Miami has the teaching hospital and the medical school. And there's no one in our area. And it's so confounding to us that, I was encouraged to hear 110 physicians, but I'm like, none of them are in Florida. It's very anxiety provoking. I can't, and he at baseline is an anxious person anyhow, and this has just catapulted his anxiety, which we can't both be down at the same time. I am so sorry.
Oh, no, that's actually, I think this is a problem that needs to be addressed, so I wonder if anybody else may have experiences with coordination of care and how that's worked out for them or not worked out for them.
Gosh, so much of what everybody has said resonates with me. I could talk for an hour about all this stuff. I encourage you to get your rheumatologist or get a rheumatologist, make them the quarterback, because they're most likely to know about this.
And he wanted to talk to my husband about philosophy because he's a philosopher PhD. So he just wanted to chat about philosophy. The 3 doctor's appointments were talking philosophy. It was never.
As long as he's not charging by the hour, that works, right? Or maybe by the 5 minutes. But I have found my rheumatologist is a bright guy, and that's been a blessing because he's been able to talk intelligently to everybody else. But the first person to actually discover it was pulmonology, and I said, "Oh, this goes to rheumatology then, right?" And that they work together. So you do need a quarterback, I think, is my feeling. That's been useful for me. But boy, so many of the other things that people have talked about resonate for me. I'm lucky, I feel, compared to a lot of patients here, in that the only organ that's affected for me so far is lungs. And I don't know if my manifestation rings a bell for anybody, but it's a little different from what I've heard other people describe. My symptoms started as fatigue and some shortness of breath. And when COVID hit, at one point people said, "Oh, you should go buy yourself a pulse ox." Right. And I have some background in this stuff. So I feel like I bought pulse oxes for all my family. And mine was always low. I was chronic around 91, which is not needing oxygen, but it's not normal. And I did feel more tired and more fatigued than I had been as a younger man. So maybe I'm just getting old. Maybe I'm way out of shape. It's always been true. But I went to my PCP, and the PCP is like, "Oh, the machine's broken." I'm like, "I have 3 of them. They're all the same, right? And everybody else is I don't know, how to do a control." And he said, "Do you want a referral to pulmonologist?" Yes. And so pulmonology wasn't a whole lot more helpful at first, right? They were like, well, they did PFTs and they did CTs, which is the right thing to do. And the PFTs came back a little surprising too. And I wonder if anybody else says this. I did not have obstructive or restrictive lung disease, but I had impaired diffusion. My DLCO was 2 standard deviations off the mean, Z-score -2, which is unusual, right? That's only a couple of percentile. And I think that accounts for my lowering of IQ and fatigue. And, I feel like crap when that occurs. And it's chronically there, although it goes up when I'm stressed, and my heart rate goes up and things like that. But so the pulmonologist, like, I don't know what's causing this. Okay, sort of ILD of unknown origin, and suggested, well, maybe it was due to a history of GERD, and maybe it scarred my lung tissue, which I never quite bought because I've always never felt that I had GERD severe enough to permanently scar my lung tissue. It just didn't make sense to me that it was that. And it wasn't until, and I got put on LABA, ICS, beta agonists, and inhaled corticosteroids. And that did have some, you asked, did that help? And it did help. It moderated a bit, but it wasn't a cure. I've just started Rituxan, so I'll find out whether that is a cure or not. But so I'm still on that, and I'm eager to go off some of these things if they're not actually beneficial. Maybe a little asthma, but so the experience has been complicated. I had 2 flares in the summer, pretty good flares. PO2 down into the low 80s. That's getting to the level where you need supplementary oxygen. And that triggered something which pulmonology and I had been putting off for a long time, which is doing a bronchoscopy. It was the bronchoscopy that was really diagnostic. Obliterative phlebitis, presence of IgG4 positive cells, lymphocytic infiltration, store-form fibrosis, they clear, right? Right. They did brush by, and on the way there was other sort of stuff. They were doing sputum samples, and they were culturing stuff, fungi that are kind of normal. It was a red herring, right? I didn't really have fungal infection of the lungs. Okay. But, they were looking for other things, right? It wasn't until I had these flares and they did the bronchoscopy and had real images to look at. It's like, oh, look, this, I think the obliterative phlebitis is the one that kind of seals the deal. You tell me if that.
Yeah, that's one of the, in addition to looking for the IgG4, the elevated IgG4, there's other things like obliterative phlebitis that you look at that are in story-form fibrosis, kind of like buzzwords that, that make it more specific that that's the right diagnosis.
So for me, it was getting the bronchoscopy that led to the diagnosis. And it had been years from my reporting of symptoms before that finally occurred and triggered people to think about this. And I didn't have all the other organ involvement, so maybe that wasn't high on people's list of stuff like that. But so much of what all of you have been talking about, I went through.
I have a colleague that I did my fellowship with, Dr. Lin at University of South Florida. I don't know if that's close to you. He is he's vasculitis trained, but anyway. But yeah, if you need resources to connect, does anybody know a good team close to Florida?
We can chat afterwards. We have found a lot of providers across the country over the course of the last year since we've really delved into IgG4 related disease to see how we can help. And I know when you hear stuff that you heard in the last session, Kat talked through the Center of Excellence approach. It's to do exactly what you guys are sitting here talking about, creating process and a way within some of the more community practice and settings to have a quarterback. And it's not always going to be the same answer, right? Like a rheumatologist, generally speaking, is the default because they primarily know this disease the best today, but that doesn't mean that won't change over a course of time or change regionally. So I'd love to connect with you afterwards and share resources that we know that are maybe in your area, and know that what you guys are asking for is something that the foundation as well as Amgen is really dedicated and prioritizing in 2025 so that we get those centers of excellence built up so you guys have answers and a way to actually manage this a little bit better for you. So there's hope, I promise.
Oh, and then I'll go back to your comments too. So if they're not thinking about IgG4, it's really hard to identify because you have to do special staining and stuff. So it's great that they're obviously thinking about it. So
Oh yeah, I have a story. So I'm a patient. My story actually all starts with the lungs as well, and it's one of those mysteries where you're not sure if anything's related, but I was diagnosed in early 2020. My problems actually started in spring of 2019. I was having difficulty breathing. After seeing an allergist and a pulmonologist and this and that, it actually turns out I had a saddle pulmonary embolism and ended up in the hospital for 4 days. And during that time, they treated the embolism. Thankfully, I'm here, but pretty close to not making it to the hospital, I guess. And on literally like the last couple hours I was there, they were like, oh, your lymph nodes are kind of swollen. We should get a CAT scan while you're here. And then that sort of, they're like, oh, well, there's something going on there. You should go see all these other doctors. In the meantime, so I eventually got diagnosed in early 2020, rituximab and prednisone at the same time. And the uh so I now see my pulmonologist. I basically have a regular pulmonologist because of the embolism, and I'm on Eliquis, blood thinner, pretty much for the rest of life, just so I don't get more blood clots. In the meantime, I've now kind of gotten rituximab every 2 years. My levels and symptoms kind of come back up, and I think before the second time and before this very last time, which was this past spring, I did have kind of almost wheezing or difficulty breathing, kind of asthma related symptoms, mainly if I was exercising. They gave me an inhaler. And even this last time around, my poor wife had to listen to me snore, which is not something that I ever really did. After the last rituximab, that all goes away, thankfully. But it's weird because I see my pulmonologist at this point once a year. But even this last time around, even when I'm like, for one, they can never tell me if, and I'm sure nobody will really know, if the blood clotting was related to IgG4, maybe it's inflammation of the blood vessels that led to something, that kept growing over time and time. But all the kind of asthma related stuff, I got breathing tests, multiple. I had, the exercise breathing test earlier this year. I had the regular one. I've had PET scans. I've had, and every time they can't really see any manifestations of inflammation in the lungs. It's probably more the upper breathing tubes, I guess, probably. But it's just interesting because it's sort of a lot of like, oh, I'll have these breathing issues. I have this pulmonologist I see anyways. And it's sort of like, well, then the rituximab happens, things kind of get better. And so it's like a dead end that like kind of nothing ever really comes. It's like, oh, I had all these tests and then nothing really happens after that because everything sort of got better for the time, In terms of just communication with the specialists and stuff, I'm really lucky that we live in New York. And so when I was in the hospital for the embolism, it all kind of I didn't have really, I had like a PCP somewhere, but I made sure that every specialist I saw was in the same hospital group. And then the number one thing is even if necessary, they're not talking, they all kind of do know each other. They can all access the records. And that has been the biggest help is that if I see the rheumatologist every 3 to 4 months, they could be like, oh, I saw the pulmonologist and she'll just pull up what happened, or I saw the cardiologist, it's all connected that way. But I know that's kind of my story.
Yeah, thank you. From a physician standpoint, I agree. It's very helpful if it's in the same system. All the specialists that are related to IgG4, communication is so much better when it's in the same system. Now, in regards to your question regarding the pulmonary embolism and IgG4, so we do know that, one of the risk factors for blood clots is an inflammatory state, so whether that be cancers or whether it be other autoimmune diseases, we've actually established there's been a link with when other autoimmune diseases are active, like I'm a vasculitis guy, by the way. So in ANCA-associated vasculitis, when the disease is active, it doesn't cause inflammation of the blood vessel, but because you have inflammation in the body, it just predisposes it to clots. And so I don't know if that's a mechanism, but we've seen that in other autoimmune diseases. And saddle pulmonary embolism is a scary thing, definitely. So thank you. Thank you. Let's head back here.
Hi, I'm a ex-patient of IgG4 disease, early diagnosed in 2006, and I was treated with a first-generation autoimmune immune drugs, Cellcept, and pretty much the results have been pretty good. And I was treated with Dr. Shield, who is one of the speakers here in this session. My question was, I just learned about this lung thing. I was not aware that is lung also one of the main organs that are impacted with this RG4? I hear pancreas, aorta, kidneys, lungs. Is what percentage of RG4 patients have been diagnosed with the lung involvement? And one other part of the question, since you mentioned about vasculitis, is G4, IgG4 impacts any correlation to vasculitis? Is there either scads or blood clotting, things like that?
Yeah. So in regards to the first question, so lung involvement is not one of the more common manifestations. It's one of the more rare manifestations. I can't say exactly what percentage. A lot of the pictures and some of the literature I delved into is, case series, of patients with lung involvement, So again, it's not one of the main feature, but it also could be under-recognized. So we may not know what the prevalence of it is. And in regards to vasculitis, so we do know that it can affect the aorta. It can cause aortitis or vasculitis of the large blood vessel. We've seen that. In regards to other blood vessels, like some of the smaller blood vessels, there is a little bit of an overlap with IgG4 related disease and some of these forms of ANCA-associated vasculitis. So there are some patients that seem to have maybe a little bit of overlap of both. So in answer to your question, yeah, we have seen vasculitis with this disease, primarily in the aorta, yeah.
And that's what the original diagnosis was. It was, when I first went for regular checkup, they said, oh, you have an aneurysm of aorta, But then when we did a CT scan with contrast, the radiologist was the one first to say, it doesn't look like it's, it seems like it is some kind of a growth. We have to do a biopsy and then we can find out whether it's a benign or if it. So and I said, I've heard about what you call a retroperitoneal fibrosis, and that was, located on the aorta, and that's when I started on the therapy with Dr. Shield at Johns Hopkins and in first generation CellCept. I think we went on prednisone, but the effects of prednisone was not, something that I could tolerate. So we went on CellCept, and it's been fine with about 3 years of therapy, and results were, success stories. So, but then later now is the recent episodes of asthma, and I had a SCAD, and that's why I was thinking that is there a correlation between IgG4 in 2006, 2007 to its coming back, or it is, going into other organs or other.
Yeah. Yeah. And, with we call it retroperitoneal fibrosis, but, and it's surrounding the aorta, but you can get inflammation, potentially on imaging. It's kind of hard to say what part of the inflammation is outside the aorta and what's in the wall of the aorta. So, definitely it can cause that. Did that answer your question?
Yeah.
Yeah. Okay. Okay.
And it's like slow decrease, like, we had almost 3 year progressive on CellCept, and it was like we went through a CT scan every year, and and it was the size was almost negligible now. So it's I haven't followed up since 2011. I have no symptoms or any issues. So.
Yeah, and with many of these features of IgG4, we're relying on imaging, like in this case, like retroperitoneal fibrosis is a great example, because you may not have symptoms initially if it's, we want to see that it's not, at some point, it may turn into more just scar tissue, which is okay. It might, and it may never go away. There may be some residual tissue, but you want to get to the point where it's not going to grow, that hopefully you've eradicated all the inflammation in there, So, and yeah, I've had some luck with CellCept or mycophenolate as well. Let's see, time wise, yeah, maybe one more, if anybody wanted one more comment. Otherwise, we'll go ahead and wrap it up. Thank you.